Thank you very much, Nida, and thanks for inviting me to this very important conference. So what I'm going to talk might be a bit different from what we have been hearing today. So Nida and Heather has been talking about a learning process when they started a new service. For me, as an infectious diseases physician, obviously working on aging for my clients is a learning process for me. I'm not expected to have this training, and while working in this area, I've actually learned a lot together with my clients. So for today, I'm hoping we are going to do a few things. So first of all, I understand that we are all coming from a very diverse background. So we will just talk very briefly on what do we actually mean by aging. And for people with HIV, do they really age at a more rapid pace than the general population? And secondly, of course, we are talking about how aging actually means for our clients, and that would obviously lead to the third very important topic for today. What does these all have in terms of implications on our healthcare provision? So first of all, what is aging? So of course, when we are talking about aging in health, we are not just talking about chronological aging, not getting older year by year through the calendar years, but we are talking about biological aging. So in fact, for our body, we have a very sophisticated system to maintain a balance. So that's what we call homeostasis. So in terms of all the cells, tissues in our body temperature, our blood pressure, the hormone systems, etc. Everything in our body actually maintain a very good balance all the time. And also we have very efficient repair systems whenever we have both external and internal stimulus causing changes in our body. So as we age, these abilities actually get impaired because of aging. So if you look at the diagram on the left, the blue line on the graph represents the situation for the general population. So as we get older year by year, in general, we do have biological aging in proportionate to our chronological age. However, if you look at the orange line on the top, it represents people getting infected with HIV. So at the time of infection, there would be a accelerated rate of aging. However, with treatment, so that's the arrow in the center, with antiretroviral treatment, the line was actually pushed from the orange line to the red line below. So obviously, with effective treatment, the rate of aging would actually be pushed down nearer to the general population. However, because of the initial acceleration in aging, even with treatment, there is evidence that aging is accentuated in people with HIV, even with viral suppression. So, of course, this diagram here is a very simple representation or summary of many of the studies performed in the area of aging. And in the laboratory, in clinical research studies, there are actually a lot of markers, what we call biological markers to represent aging. The example of this study here is just one of the examples. For example, we can measure aging in the brain using very sophisticated MRI techniques. This example here, one of the studies using MRI to measure the micro changes in different areas of the brain, and these changes would represent aging in the brain. And they compare people without HIV, people with HIV not yet on treatment, and also people with HIV on treatment. And you can see from the diagram on the right, the different colored lines there. It's very similar to the graph on the last slide showing the relationship between the chronological age and also biological aging in the brain. And you can see that people with HIV without treatment, they have a larger brain age gap compared to the general population. And this gap is narrower for those who are on treatment. So, of course, the impact of aging is not only in the brain. So this study very nicely showed using different markers to represent cardiovascular disease risk and cognitive function and other inflammation markers. And again, it very nicely showed that people with HIV or at risk of HIV actually do have a correlation between aging. In this particular study, they used the telomere length, which is some part of the chromosome, to represent aging. And again, very nicely showing that aging actually can be manifested in all these different organ systems. So with that, it is not surprising that for people who do age more quickly, they would have some sort of clinical manifestations. And what are these? First of all, there are a lot of comorbidities, or what we call chronic diseases, that are related to age, meaning that they would have a higher incidence as one gets older. So if you look at the graphs here, the bar charts here comparing people with and without HIV. For example, if you look at the bar for those without HIV on the right, for those aged greater than 65 years old, if you look at the pattern of the bar here, you will see that it's very similar to the people with HIV in the age group 55 to 59. So the different shades of gray here represent the number of these age-related comorbidities among the population in these different groups. So it's a very nice and sort of a easy to understand picture to let us see that people with HIV generally age around 10 years earlier than people without HIV, as represented by the number of age-related comorbidities. So they do have onset at a younger age, and also at a younger age, they would have multiple comorbidities. And other than these very well-defined chronic diseases, people, if they do age earlier, they would tend to have what we call geriatric syndromes. So geriatric syndromes is not something we as an infectious disease physician think it's easy to understand because it's not a very well-defined disease like a stroke or hypertension or diabetes. Rather, it represents some constellation of symptoms which are common in older people. And also it is multifactorial. It can be due to a lot of different factors, and also it might involve different systems. So here are some of the examples of geriatric syndromes. And of course, I'm not going to go into these one by one, but just to give you an example. For example, cognitive impairment. So when we are talking about memory impairments in older people, very often we think about dementia or Alzheimer's disease， 即係以前叫老人痴呆症啦，而家我哋叫認知障礙症啦。However, whenever a person, especially an older person, complain of some memory impairment, memory complaints, it really doesn't mean that they have dementia or Alzheimer's disease. It could be due to things like depression, or sometimes when people, older people, they have some acute illness, for example, influenza or an urinary tract infection, they can become a bit confused without actually having infection in the brain. So sometimes it could be medications. People with older people sometimes having a medication, symptomatic medication for colds and flus, they actually can develop some changes in their mental state. So whenever a person have cognitive impairment or some mental state changes in the older people, it can be due to different factors. So that's what we would observe for people with geriatric syndromes. And of course, tackling these problems would be less straightforward. We have to have a very comprehensive understanding of what's going on for that particular person at that particular moment. And another very characteristic geriatric syndrome is what we call frailty. And you can look at the definition as shown here. And the diagram here, mainly, I would like to let you know that although there are a lot of different ways to define frailty, the one I've shown here is a very classical definition of frailty. So in general, we have to measure things like gait speed, grip strength, among the other domains or parameters. And you can imagine that in a routine medical clinic or an HIV clinic, these won't be the things that we will be monitoring routinely for our clients. Therefore, this actually poses some of the challenges that when we are actually tackling the problem of aging in people with HIV. Another important aspect is that having these comorbidities and geriatric syndromes actually would have impact on their quality of life. This is one of the studies we have done in our clinic at Prince of Wales Hospital. So sarcopenia is loss of the function and also the mass of the muscle as one gets older. And importantly, the prevalence of sarcopenia was actually very high among our clients. And what's more important is that people who have sarcopenia or severe sarcopenia had actually worse health outcomes, including problems with mobility, problems with the usual activities of daily living. So this means that having a monitoring system and to detect the presence of these geriatric syndromes would be very important in their health outcomes. And of course, I cannot refrain from mentioning the impact of double stigma between HIV and also aging. So people who get older with HIV actually may encounter new or compound problems because of the coexistence of both issues. For example, they do have worse physical or mental comorbidities because of aging and because of HIV. And sometimes disclosure of HIV status becomes an issue. After years of infection, when they do have new comorbidities coming in, they might require hospitalization because of various reasons. The disclosure problem to family and close members who have been unaware of their status for years might become an issue again. So these very practical scenarios would bring up these issues of stigma again, even after years of diagnosis. Of course, not everything is negative. There are also observations that as one age, they actually have better mental health, better ability to tackle new issues when new problems in terms of physical health come up because of the experience in managing a chronic disease for a long time. So what does all this bring at the end of the day is that in terms of the healthcare service delivery, for both the individual and the community at large, the issue of aging would actually have implications on what we are providing and also what our clients actually need. First of all, early initiation of ART, that's very important. And studies, for example, the START study, SMART study, et cetera, have all shown that early initiation of antiretroviral therapy not only improve immunity and reduce AIDS-related complications, but it also reduce non-AIDS-related complications and all these chronic comorbidities. So starting ART early is very important. Secondly, the diagram I've shown here actually comes from the European AIDS Society guideline on HIV management. This is the table of contents page, obviously, and the right column that I've highlighted represents all the medical conditions not directly due to HIV, meaning the screening and management of diabetes, high blood pressure, chronic kidney diseases, et cetera. So you can see that the proportion of HIV and non-HIV or directly related to HIV actually is of equal or even more important in the management or long-term management of people with HIV. And thirdly, as I've illustrated with all these examples of geriatric syndromes, it's very important that we do monitor their intrinsic capacity or their functional ability to maintain their expected quality of life. And I'll elaborate on this a little further. Do what I've just summarized in the slide above, there are obviously some challenges. Currently in Hong Kong and globally, basically everyone's providing antiretroviral therapy once a patient is diagnosed. What is the greatest challenge for older people is that they are often diagnosed late. So if you compare the age distribution curves for people with HIV and those with AIDS on the lower diagram, it's quite obvious that people who are older, a higher proportion of them do present late with AIDS complications. So the prevention services, testing services for targeting older people, that's very often something that's left behind. So that's maybe a thought for us, for people here, the stakeholders here as well. I've talked about comorbidity screening and management. There's no one-size-fits-all best practice model, obviously. In different cultures, different settings, the best way to provide these services would differ and might even differ for person by person in the same community. And it would be important that when we are designing these service delivery model, we would have to provide a differentiated service needs to cater for the different needs of the population. And finally, the WHO actually had a healthcare model on aging. And it actually comprises both intrinsic capacity, which is shown on the diagram here, looking at the different components that would maintain a person's ability to do what they actually want to do. But also importantly, the external environment is also very important. And that would include all the services and the infrastructure in a society that would enable an older person to live the way they would like to in a particular society. So therefore, in terms of healthcare, of course, these are the things that we would like to maintain and also bear in mind when we design the components that are essential for our healthcare services for people with HIV. So with all that, I hope I didn't give you a too pessimistic picture of aging, which is basically inevitable for any of us here. But all these models, diseases or conditions that I've discussed, I think brings a very important issue is that aging well is possible. We can't prevent aging, but we can choose to age well. And this is also something that we can do for ourselves and also for our clients. So thank you very much, and I'm happy to answer questions.